Hello, Dr. Ashutosh.
Yeah,
Yes, you are live, sir. You can start your presentation.
okay. Good evening, everyone. My name is Dr. Ashutosh Jha. I am working as a consultant in orthopedic department at Columbia Asia Hospital, Ghaziabad for last 5 years. Before joining Columbia Asia, I was an assistant professor at the Sports Injury and Joint Disorder Center at Safdarjung Hospital, New Delhi. So, because I have special interest in sports injury and its related disorders, I will be talking today about a very common sports related injury called as anterior cruciate ligament injury. This injury is not only restricted to the sports person but can be seen in common man in their day-to-day life. So this way this injury is very important for common person also. I hope that today's participants would include doctors, physiotherapists, as well as my common friends also, common colleagues who are non-medical. So I would try to make the presentation very simple so that everyone can understand about this. So as I said, I am working as a consultant orthopedics in Columbia Asia Hospital, Ghaziabad. And before joining Columbia Asia, I had gone to South Korea for a special trauma fellowship. There I have gained expertise about the latest technologies of how we can manage the cases of ACL injuries. So this is the team way back in 2011 when I was there as a trauma fellow. And I had a very good time spending with the professor who is standing second from the right, Professor J.K.O. So I would like to thank him for his valuable support and guidance. So coming to the ACL injuries, what is ACL? ACL stands for Anterior Cruciate Ligament, and it is one of the four main ligaments of the knee that keeps the knee stable. So here in this picture you can see that there is patella in front, and then there is the anterior cruciate ligament, there is a posterior cruciate ligament, then the medial collateral and the lateral collateral. So the MCL, LCL, and the ACL and the PCL are the four main stabilizers of the knee joint. So this is how a ACL would look when you see them live in the surgery. And ACL has two different bundles. There is the anteromedial bundle and the posterolateral bundle. So how the ACL is actually injured? Usually injury is with a twisting force directed to the knee by a direct blow to the outside of the knee with a contact or non-contact mechanism, changing directions rapidly, slowing or stopping suddenly while you are running, or when you are landing after a jump and you land incorrectly. These all can lead to anterior cruciate ligament injuries. So this is a simple example of what kind of mechanism leads to ACL injury. It is mainly the twisting kind of injury that leads to ACL tear. So what are the signs and symptoms of anterior cruciate ligament injury? So ACL can be classified into two different categories: acute ACL injury and chronic ACL injury. The acute ACL injury is characterized by marked pain and pop and significant knee swelling and difficulty in bearing weight. The chronic ACL injury can give you feeling of looseness in the knee, feeling of buckling or giving way or instability, and sometimes it can lead to pain and swelling. So there are two different presentations of ACL. When it is acute, it will lead to severe pain, significant swelling because of bleeding in the knee, and difficulty in weight bearing. But a patient with a chronic ACL injury will not have much pain or swelling, but he will only feel that the knee appears loose. कॉमन लैंग्वेज में हिंदी में इफ यू टॉक द पेशेंट विल से कि घुटना लोड नहीं लेता है या घुटने में झटका आता है, घुटना बेकाबू हो जाता है. दीज आर द कॉमन टर्म्स इन विच द पेशेंट प्रेजेंट टू अस. It will be like feeling of buckling, giving way, or instability. Occasionally there may be pain and swelling also. With acute ACL injury, there may be associated injuries like lateral meniscus injury and medial collateral ligament injury, posterolateral corner injury, and posterior cruciate ligament injury, and sometimes there is anterior cruciate ligament injury also, articular cartilage injury also. So how we diagnose a ACL injury? Most important is history. Patient will say कि he landed incorrectly or he slipped on a floor while coming down from the stairs, his knee bent suddenly, and there will be history of some popping sound. So that history is very important. Sometimes patients with road traffic accident can also have ACL injury. But if the patient is a sports person or if he is a common man but still playing with children, kids, jumping, then also it can be injured. So history is very important. On examination, X-ray is usually most of the time normal, but it should be obtained to ensure that there is no fracture. MRI is the gold standard and excellent for evaluating not only the ACL but also the meniscus, cartilage, and other ligaments. There is a lot of confusion regarding when to go for MRI. People say that if immediately after the injury you go for MRI, you will not be able to pick up the ACL tear. But these are very old thoughts. Now with advanced MRI techniques and with good experience among radiologists, we can pick the ACL right in the emergency room just half an hour after the injury, and there is no confusion regarding the further management of the problem. So in acute ACL injury, as I said, the patient might be having popping sound at the time of injury. There would be sudden onset of pain along with fullness in the joint or effusion. The joint will appear painful or tender. There might be tenderness on the inner side of the knee, which is because of the injury to the MCL. Sometimes the meniscus is also injured and that could lead to knocking. And when patient starts to walk, he will not be able to bear weight on the leg and his leg will not be supporting the body weight and he will complain of instability. In chronic cases, pain is less remarkable, swelling is less. The most important complaint is instability. And this would occur when patient is having activities in which the rotatory stabilization of the knee is required. Like you would be having difficulty in running, climbing stairs, and patient will also be having frequent episodes of locking. So locking is a very special condition in which patient will feel like his knee has stuck at a particular angle and he will neither be able to straighten the leg nor bend the leg, and any attempt of movement will be very painful. And after some time, all of a sudden, the knee is unlocked and then patient will not have any complaint. He would say, I'm perfectly fine. So this locking happens because of the injury to the meniscus, and meniscal injury are usually associated with injury to the ACL. Clinically, if we do the test, there are certain tests like anterior drawer test in which we give a forward thrust to the knee in flexion, and we have to always compare it with the other side and find if the affected knee is lax or not. Lakeshore test is more useful when the patient is having a painful and swollen knee. You don't have to bend the knee 90 degrees. You can do it in 15 to 30 degrees of flexion. Pivot shift test is best appreciated when the patient is under the effect of anesthesia, and we usually perform it just before starting the surgery. So now coming to the MRI here, if you see on the left of your screen, there is a injury to the knee. There is a lot of white colored intensities, which is hemarthrosis, but you can see the ACL has been labeled normal because a black thick band is running from the tibia to the femur. This ACL is intact. But on the right side, the ACL is torn. So you cannot find that black line on the image on the right side. So we have a grading. Grade 1 is ligament which is intact but stretched and joint is stable. Grade 2 is ligament is stretched but intact, joint is unstable. The partial tear. And grade 3 is ligament is broken, that is completely torn. So what will be treatment of a ACL tear? Acute stage, always RICE, that is rest, ice, compression and elevation. So you have to give rest to the leg by applying some kind of bandage or a splint or a brace. Apply ice as much as you can tolerate, 3 to 5 times a day. Give compression with crepe bandage and keep the leg elevated and take rest. You should not be putting weight bearing or putting weight on the leg immediately after a suspected ACL injury because it may further aggravate the problem. And you can use braces as advised by your doctor or a physio. So now that it has been confirmed on an MRI that your ACL is torn, you had symptoms of instability, what next? Then you will visit an orthopedic surgeon and the doctor would tell you that you have a torn ACL. But does everyone with ACL torn injury need a surgery? The answer is no. And most of you will be surprised. I tell you why. Who does not need a surgery? A patient with very advanced arthritis. Patient is more than 50 years of age. Knee has already changes of osteoarthritis. If you do a ACL reconstruction also, it will not help much to the patient. Sometimes it may even aggravate the problem. I rarely do ACL reconstruction in patient more than 50 years of age. Patients who do not do activities that require an intact ACL. We'll come to the point number 2 in detail at what are the activities that require intact ACL. Third point is patients who are not interested in committing to the post-operative rehab because ACL is a very delicate surgery and the success of this surgery entirely depends upon the post-operative rehabilitation protocol. Patient has to undergo a very dedicated and meticulous physiotherapy for at least 3 to 4 weeks. If patient does not have time or commitment for the post-op physiotherapeutic rehabilitation, surgery is not going to give him a good result. So if you ask me who are the patients who despite having an acute or a chronic torn ACL can be managed conservatively, I would say those who had grade 1 injury or those with grade 2 and grade 3 injury but without a symptom of instability. So the whole idea is that if you have a torn ACL but you are not experiencing instability, there is no need to rush for surgery. If your sedentary lifestyle, like you are a housewife or a desk job worker, or you don't have much of mobility because of some other issue, then this surgery for ACL is not an essential surgery for you. Surgery should also be advised to children with caution because their growth plates are open and during the surgery, the growth plate might be injured. There are newer techniques in which we can perform ACL reconstruction in children with open physis also, but we have to take consideration into that also that growth plate might be getting injured. So here are two patients. One is Yuvraj Singh on the left and then second on the right is Mr. Sanjeev Kapoor. So you all would agree that Yuvraj Singh needs ACL and Sanjeev Kapoor probably does not. But you all will be surprised to know that before the 2011 World Cup, which India won and in which Yuvraj Singh was selected man of the tournament, I had read in the newspapers also and reviewed in the internet also, Yuvraj Singh had a torn ACL and he had been advised surgery. I'm sorry, it was not the 2011 World Cup, it was 2007 T20 World Cup, in which Yuvraj Singh has hit 6 sixes in an over and made a world record. So before that tournament, Yuvraj Singh had a confirmed torn ACL and he was advised surgery. But because of the prolonged rehabilitation protocol, there was not enough time for him to go to the surgery and then again come back and participate in the T20 inaugural World Cup. So he decided not to go for surgery, and he has hit 6 sixes in an over even without getting his ACL repaired. So this makes things more confusing, but I would like to clarify the confusion slowly. So if we say that we have to categorize the patient into categories based upon conservative management, we can say there are 3 different group of patients with a torn ACL: copers, non-copers, and adapters. Copers are those who somehow reduce their abilities, activities, and try to manage with their day-to-day activity without having much need of an ACL reconstruction. They would take short steps, they would not climb stairs, they would not be running or doing brisk walking, they would not be running on treadmill. They somehow try to cope with their situation. So these are copers. Non-copers are those who somehow do not adjust with the reduced ability of their knee. They are the ideal candidates for the surgery. And there are another group called the adapters. Adapters are those who somehow convert their inabilities into their strengths. Like Yuvraj Singh, he had gone aggressive physiotherapy of his hamstring and quadriceps, and he had overcome the disability of his ACL injury by doing strengthening of his other muscles. So that way, without even a ACL surgery, he could perform at the highest level. So, who would need a ACL reconstruction? Patient who perform activity requiring an intact ACL. Patients with other associated knee injuries. Sometimes you have a ACL injury along with meniscal tear, cartilage injury, or MCL or LCL injury. They are the candidates for surgery. Young patients with an otherwise healthy knee can also be an ideal candidate. So now I had talked previously that what are the activity, how a common man can know whether he should go for a surgery or not. There is a list of activity which can be divided into 2 groups: ACL dependent activity and ACL independent activity. Dependent activity like playing basketball, cricket, kabaddi, wrestling, high-end aerobics, hiking, laboring job, any activity when the knee buckles after the injury. These are indication for ACL dependent injury. Non-dependent is like walking, jogging in a straight line, desk job, riding a bicycle. You can very well do without an intact ACL. What if you have a ACL tear, you have instability and you don't get it corrected? What would happen? Every time your knee would buckle, you risk injuring other vital structures like meniscus, ligament, or the articular cartilage. What happens if the vital structures are injured? It would rapidly accelerate the arthritis. 90% of the patient will have meniscal injury and 70% of them will have a condyle damage at the end of 2 years after a primary ACL injury. What are the prerequisites for ACL reconstruction? Patient should have normal pain-free range of motion, good muscle strength, no evidence of degenerative joint disease. As I said, patients with osteoarthritis will not be benefited from a ACL reconstruction. Many times patients with knee pain go to a general physician, then they have been advised for a MRI. The MRI will say mucoid degeneration and partial tear of ACL, and then the patient come to us that my ACL is torn and why don't you replace it? And then I have to make them understand that your problem is not a traumatic ACL, but a degenerative kind of thing. So even if we replace it with a new ligament, it would also degenerate in 6 months or 1 year's time. So it's not going to help. Patient willing to cooperate with physiotherapist. That is a prerequisite. Sometimes patients go to physical therapy pre-operatively to get their motion restored before the surgery. So now coming to the technicalities of how the procedure is done, you have different type of grafts. We have divided the graft into autograft and allograft. Autograft is something which is taken from your own body, like here we are showing bone, patellar tendon bone. So a small piece of bone from your kneecap, that is patella, then there is a tendon, and then again a small portion of bone from the tibia. This will constitute your graft. But commonly we use hamstring grafts. Hamstrings are easy to harvest and they have less morbidity after the surgery. And there are allografts also. Allograft is a graft which is taken from somebody else. It's not from your own body. So not available in India, the cadaveric. But when I was in South Korea, they used to do it frequently. So then the way we donate our cornea after our death, they also used to donate the tendons, and tendons are harvested and then they are restored and kept in the refrigerator and can be used for different patients. These are allografts. There is no convincing evidence that which one is better. It's a personal choice. So coming to the conclusion, all torn ACL do not require a reconstruction. Timing of surgery is debatable. Timely surgery prevents further damage to the joint, and graft choice should be based upon the need of the patient. Any attempt of reconstruction is futile without proper physiotherapy. So with that, we conclude today's session on anterior cruciate ligament injuries, and I hope you have enjoyed the session. Thank you very much.
Yeah, thank you so much, Dr. Ashutosh Jha. It was an insightful session, sir. Thank you so much for sharing this.
Jay.
And I would like to thank you on behalf of all the doctors and audience who joined today and from Live Rate. And we
Yeah.
look forward to host you again in future, sir. Thank you so much for your time.
Thank you.